Welcome everybody to our September Health Equity Webinar Series session. I'm really excited about the conversation. The panelists and I were just talking a little bit before you all joined, and we were talking about what important topic this is, particularly for Black communities, topic that we don't always talk about, and that's end-of-life care and preparing ourselves for what's going to actually happen to all of us. I know we don't like to see it or hear it that way, but unfortunately, we don't live forever. I don't know if I want to live forever, so that's also a thing. But just really thinking about you taking the time to plan and think through what it is you will need whenever end of life happens. And that could be for some folks in old age, and that could happen for others earlier due to accidents, illness, disease. And so it's important for us to think through our wishes, talk with your family, and we're going to have a conversation about why that's important. What does that mean? What are your rights? What are your what can people expect, and how do you can prepare yourself and your family for end of life? We are very excited with the panel that we have today. Most people know who I am, but I'm Lydia Isaac. I'm the Vice President for Health Equity and Policy here at the National Urban League. And joining us, and I'm going to use her nickname because I do not want to mess up her name, is Missy Moore, which is interesting because I know a Misty Moore. But anyway, Missy Moore, who is a nurse educator at Bridgepoint Continuing Care Hospital in the Capitol Hill area. Missy is a nurse, a consultant, and a community activist in DC, and has worked over 30 years as a nurse educator, currently at Bridgepoint Nursing and Rehab Center. She has extensive experience in end-of-life care and is a member of the Hospice and Palliative Care Nurse Association, and she also serves as a member of the African American Leadership Council. In addition to Missy, we have Ayana Woods, who I always say this, I also went to school with Ayana, so this is really exciting. Didn't realize that. It's so nice to have a familiar face, but Ayana is a patient advocate and a public health professional with over 20 years experience in developing health education and outreach programs to promote wellness, successful management, and chronic illnesses. She was the president of or the executive director of the End of Life Choices New York, and she currently is serving as a member of the African American Leadership Council at Compassion and Choices, and she also is the deputy director of U.S. Advocacy Relations at Bayer Healthcare in hematology and cardiovascular renal health. And last but not least is our own Dr. Lillian Mehran, who is our scholar in residence here at the National Urban League. We're very excited to have her. She's really been a driving force behind these webinars, and particularly this webinar. She has a passion for addressing inequities and injustice in the healthcare system, especially with those with serious illnesses and those serving as caregiver. She just finished her dissertation, and we're really proud of her. And she did research focused on experience of navigating the healthcare system when serving as a caregiver for terminally ill patients and the impact of those experiences. So this wonderful panel here is going to really lead us off and talk through issues in end-of-life care. But first, Lillian's going to do a short presentation just to set the stage, to set the foundation, to set what we're talking about, because the idea of end-of-life care or end-of-life planning is a large one. And so we just want to do a little bit of focus before we get into some more nitty-gritty. So Lillian, I am passing it on to you.
Thanks so much, Lydia. I'm going to share my screen, so just bear with me one moment while I do that. So so as Lydia mentioned, I'm going to give a very, very short presentation, just going over some of the terms that we're going to be using, and a very preliminary sense of what some of the inequities are. Unfortunately, there are many, many, many. And so in terms of the definitions that I'll be going over, I'll be talking about, as you can see here, around advanced care planning, palliative care, hospice, and then I'll be going into these inequities. So advanced care planning is a process. Often, I think when we talk about advanced care planning, we think of it as a one-time conversation or filling out a form, but advanced care planning is truly a process during which a person reflects on their values and wishes and what matters to them. And those, by sharing those and reflecting on those and writing those down, folks that may need to make decisions for us later on if we're sick and we're not able to communicate our own wishes, know those values, know those wishes, and are able to honor us in our lives and our choices. And so again, it's a process of reflection, discussion, and in many cases, documentation. I'll be getting to that in just a moment. And we're talking about this in the context of end of life care, but really advanced care planning is crisis planning. I know for some folks, myself included, who have had to go under anesthesia for a surgery, something comes up while you're under, someone else needs to make decisions for you. Having that information is critical. And also, if then when you come back, you're able to make your own choices, then again, you'll be the one doing that. So again, we're talking about in the context of end of life planning and care, but really it's crisis planning. And it's not just for those who will make decisions for you, but also for you by thinking about what matters to you early on, if and when, and likely for much of us, it'll be when we have to make our own decisions. It can also be helpful to have thought through some of this before. And there are a number of decisions that you'll need to make throughout this process. And in many cases, we document those on forms. So advanced directives are a piece of advanced care planning, and they're the documentation piece. And most states have their own forms for some of these. And I've listed some of the common ones here. And so one of the big ones that we talk about, certainly in New York, but it's relevant across all states, is what's called the healthcare proxy or healthcare power of attorney. And basically that is a mechanism, it's a form that you complete so that you can appoint someone you trust to make healthcare decisions for you if and when you're not able to make those decisions for yourself. And there can be a number of reasons why that happens. And so this person can be a friend, a family member, a minister, a neighbor. Really, it's about making sure that this is someone that you trust. And what I hear a lot in my work is folks saying, oh, well, my family knows me, I don't know that we need to talk about it. I don't know that I need to complete these forms. And I would really encourage you to have these conversations. Number one, often, especially in what's a stressful moment, it's easy for folks to forget, or I've seen a lot of cases where within families, for instance, if someone is making a decision for a parent and they have multiple siblings, that they don't all agree with each other. And at a time where folks really need to be coming together, I've seen a lot of families fall apart. And so by having these conversations, and especially by appointing one person that you trust, this is a way of really gifting this to your family. So that's a healthcare proxy or healthcare power of attorney. It's all about the person. Living wills, there's a lot of variation from state to state, but living wills are basically a description of your wishes. If you have particular ones where I would definitely want CPR, it's important to note this, or I would never want a feeding tube, it's important to note that. For most folks, I've found that it's, I think it's so situation dependent, and it's almost impossible to think of all the different situations that may come up. We really encourage folks to be thinking first and foremost about what drives their current decisions that they make when they have to make a decision for themselves medically, what matters, but also, what their values are, what their core wishes are, what makes a good day, who do you want by your side, what does quality of life look like to you? These are the bigger questions that also can be documented on a living will. A form that most folks have not heard about, and I would say even some clinicians, is called Medical Orders for Life-Sustaining Treatment, or MOLST. In some states, it's called Physician Orders for Life-Sustaining Treatment, or POLST. And basically, this is a form that documents your wishes if you have a serious illness, about what you'd want in terms of hospitalization, comfort care, various interventions. And this gets signed by a clinician in conversation with you or the person helping make decisions for you. And so this is a formal medical order documenting those wishes. The one that I think comes up a lot in movies and TV shows, and probably some of us have encountered too, especially in hospitals, is a do not resuscitate order, or DNR. And that's for folks that absolutely would not want to be resuscitated under any conditions. And so that's, again, very specific. It's about one specific wish, but I think for many of us, that's the one that we've heard about a lot. And all of these forms would need to be completed before someone loses the ability to make decisions for themselves. Obviously, if they regain it later, they can complete the form, but it's all about planning in advance of that crisis, planning in advance of something happening. And so you're prepared and your loved ones are prepared. And you can change these at any time. I know that, for instance, for my healthcare proxy, once I got married, I changed the person that I would want to make decisions for me to my spouse. And so these are not set in stone. what matters to us can change, our circumstances can change. But this is just that documentation piece. And again, it's a process, advanced care planning. It's not a one-time thing. It's an ongoing process where we share what matters to us. And those can really be, they don't have to be dreary conversations. They can really, I've had them be beautiful, and I know other folks have as well. Another topic, just changing gears a little bit, that we're going to talk about likely is palliative care. There are a lot of misconceptions about palliative care. If you haven't heard of it, you're in the majority. About 70% of Americans say they've never heard of it. And palliative care is a specialized type of medical care, just like cardiology is a specialty or oncology is a specialty. Palliative care is specialized medical care for folks living with a serious illness. And it's all about quality of life. It's focused on preventing and relieving suffering, physical, emotional, in many cases, spiritual. They have clergy on staff, chaplains on staff, and also social. So for instance, caregiving needs. What I think is really wonderful about palliative care is, again, it's focused on quality of life, but it's not just for those who are approaching the end of life. It's not just limited to pain. It's regardless of diagnosis or prognosis. And so, for instance, if someone is going through cancer treatments and they may recover, that's wonderful. We hope that to be the case. And palliative care can be provided right along chemo, right along radiation while they need it. And there's a lot of, again, misconceptions about palliative care. I think often when we hear the term, folks only associate it with end-of-life care. But again, palliative care is for those who need it with a serious illness, and it's throughout the course of an illness, not just approaching the end of life. Hospice, which is what it often gets, I think, confused with, is specifically those who are approaching the end of life. Usually that means a life expectancy of 6 months or less if the disease runs its typical course. And we say typical because it's really hard to predict what the future may look like for one person. I know folks who have been in hospice for many, many years, and I know folks where it was much shorter than expected. And so it's based on averages, and it's a type of palliative care. So it's all of the benefits of palliative care, again, as I mentioned, addressing spiritual needs, social needs, mental health needs, physical needs, but it's for those, again, who are approaching the end of life. And the other key piece of this is that it's for folks who are no longer receiving any kind of interventions like chemo that are primarily intended to cure. So for many folks, they've tried a lot of things and it hasn't worked, or they've tried a lot and they say, you know, I don't want to keep doing this anymore. And so that's where hospice kicks in. And I think a big misconception about hospice, you see, I'm using the term misconceptions a lot. Unfortunately, there are many, and I'm so happy that you're here so we can talk about it. A lot of folks think it's a place. So you have to leave your house, go to an institution to receive hospice care. And while there are hospice homes where that can happen, by and large, hospice care takes place at home, which is where the vast majority of folks say they would like to be at the end of their life. It's not round the clock care. They do provide care in the home, but by and large, it still is reliant on a caregiver. In many cases, that's a loved one who's there with you 24 hours a day, but they're on call, they're available if something happens. And again, they're there for you, but also they're there for your loved ones. So they're there to help caregivers. One of the things they do also is provide grief support, but they can connect to resources. They can make sure that, you know, your insurance is covering what it needs to cover. And so it's really a wonderful thing, but it is very underutilized, which is the next thing I'll mention, are inequities that come up in all of this. And I suspect for much of you, I think most of you are looking at this and thinking, oh, this is not really that different. And unfortunately, a lot of the inequities that we see at the end of life pop up far before someone is at the end of life. And so, for example, when it comes to pain management, what we see at the end of life is that Black patients are less likely to even have their pain assessed, let alone treated sufficiently. Also, Black families report that their loved ones are not having as great communication as white patients with clinicians. So maybe they're not really being heard, or I think they're not really being heard. And also some studies have found that in neighborhoods that are majority Black, the pharmacies in these neighborhoods are less likely to carry opioid prescriptions. So even if you do get that prescription and you need it, it can be harder to fill it. So there are a lot of issues around pain management, a lot. There are also some other issues. One of them is that most Americans have not done any kind of form of advanced care planning. Only about 30% have. And that number has remained the same for quite a while. So we need to be doing more around that. But in some communities, the rate is lower. So amongst Black Americans, about 18% have done any kind of advanced care planning. Palliative care programs, which I hope that you're interested in learning more about now, are also disproportionately in urban neighborhoods. So only about 17% of rural hospitals have programs, palliative care programs. And also hospice utilization is not the same state by state. So Utah has the highest rate. So about 60% of folks who are, and this is based on looking at people who receive Medicare, folks that are eligible for hospice, about 60% of them in Utah will receive it. New York is the worst. New York has the lowest hospice utilization rate at about 25%. And even, so we're talking about state variation, but again, there's also community variation. And there are a number of reasons why this may be happening that I'm looking forward to chatting about. But Black patients are significantly less likely to receive hospice care. So only about a third of eligible patients receive hospice care who would otherwise benefit from it. So I'm going to leave that there because I'm really eager to have this conversation and hear from my fellow panelists on the whys and the what we can do about it. And so I'm going to stop sharing. And Lydia, I turn it over to you. Looks like Lydia may be having some connectivity issues. Oh, no, you're back, Lydia.
Thank you, Lillian, for that wonderful introduction. I'm back. Sorry, y'all. My internet is unstable. Can you hear me?
Yes, we hear you. Okay, so maybe while Lydia, I know she was struggling with this before.
Okay, sorry, y'all. I'm going to go off camera and hoping that will help. And then as the panelists are answering, I'm going to try to find a more stable place to sit.
Okay,
but I'm going to start with.
Oh, we lost you again, Lydia.
You know what, Lillian, I'm going to let you just start with I was going to start with why it's so important to have advanced care planning. Can you start with that question? I'll find a better place to be.
Sure. So, and right before we started the webinar, we were actually talking about the value of advanced care planning and how even I think within our own family, sometimes we need to be the folks guiding these conversations. But the first question I think that Lydia wanted us to discuss is, why is advanced care planning really so important? And Missy, maybe can we start with you?
Certainly. Thank you, Lillian. I feel like it's important. Part of it, one of the reasons is because it really is a gift to your family, because it keeps down a lot of frustration. It keeps down a lot of guilt. It helps to decrease grief, because they have a better understanding of what it is that you wanted. They felt like they've done what you wanted to do. And the other is you really feel empowered to do what the person wanted to do. So, my personal story is, in 2017, I lost my oldest son to cancer. And I had to have a really difficult conversation with my son, who was in his 30s. And I knew that they were going to come talk to him about advanced directives, but I went myself and said, son, I want to talk to you about how you want to live. What is it that's going to be important to you? And we talked about those things: who he wanted to see, where he wanted to be, what he wanted to do. And he told me those things, and we did those things. And I only had 24 days. So from the day that he was diagnosed to the day that he died, I had 24 days to live out what he wanted. And it was probably the most important conversation I'd ever had with my son. Now, I couldn't imagine what I would have been through if I hadn't asked that question. I probably would have been more anxious. He probably would have been more anxious. But I just felt that he knew that I was going to be there, that it was only going to be the way that he wanted. And that he could rest peacefully. It was good for both of us. The other is that I felt strong that if I can just talk to him about this, then I'm going to be okay. And that's what I did. I can't make it any more simpler than that. It hurt, but I was able to do it because I knew it had to be done. It was important to do it. So
Thank you so much for sharing your story, Missy. And I know when we've spoken before, it's so poignant. And so I think when you talk about it as a gift, I think that really touches home with me and conversations that I had with my father at the end of life. But also the other thing that really stood out to me is a lot of the time when people think about these conversations, they think about it, as if dying isn't living. Dying, you're living. It's about life. It's about what life should look like and what you want, what values drive your life. So thank you for sharing that. And I wonder, maybe Ayana, you can speak to this, and Missy, of course, I want to hear your thoughts. Why don't these conversations happen more? What do you think are some of the challenges or barriers that exist to having these conversations?
Sure. I think it's fear and I think it's avoidance, but I think people don't ask. It's funny, when I first took the job at End of Life Choices New York and I told my dad what I was going to be doing, he said, when you tell people at a cocktail party what you do, they're going to run away and pretend they need to get something to drink. But actually, when I told people what I did, they started opening up. Every time I mentioned, I'm sure it's the same for Missy and Lillian, every time we talk about the space we work in, people want to share, they want to ask questions. And so I think we're just not creating spaces for these conversations, and we're not normalizing these conversations. We're looking at them like taboo topics. And so we really need to integrate them in normal conversations, in family gatherings, hopefully sharing resources with people who look like us, telling their stories. And I think that's the way to open it up. But I just think we're just not creating opportunities. We're afraid. We're scared to think about our mortality or the mortality of loved ones, but we are all mortal. Although we are superheroes, Black people are magic, but we will die. And we need to talk more about these things more openly. And so I think even professionals in the space, social workers and physicians, they're not even comfortable talking about it. So they're not even broaching the topic with their patients. And I also think about other spaces like work sites and other opportunities to engage in these things. We're not doing it. So I think once we open it up, it'll happen. But generally, people are just not comfortable. They're afraid. It taps into past traumas and pain and fear. Yeah, once again, I think it's just so important. I'm glad we're having this conversation today, and thank you for inviting me to be part of it.
Lillian, I just wanted to add on to what Ayana was saying. In the past few months, I've been working with healthcare professionals to help them do a better job at talking about advanced care directives. And I'm doing a training. And what I've discovered is that the healthcare professionals aren't doing a great job of explaining it. So when we're asking someone to sign an advanced care directive and they don't necessarily understand what it is, they're not going to sign it. So, I had maybe 50 healthcare professionals on a Zoom, and I said, can you tell me what a do not resuscitate is? And they went through this long, elaborate definition. And I said, that's great. Now I want you to explain it to me at a 6th grade level, because advanced care directives are written at a 9th grade level, but the average person understands health information at a 6th grade level. So they kept trying to explain it. And I said, this is why the patients and families aren't signing the documents. So until we can get to a level where they understand what we're saying, they're not going to sign it. And I always have a sense of humor. A gentleman said, I said, so I want to talk to you about an advanced directive. He says, I know what that is. I said, good. He says, I want everything done. I said, okay, well, what does that mean? And you know what he said? Well, what you got? And I was like, well, would you like to have a gastrostomy tube put in your stomach? Would you like to have a ventilator put on? He says, I don't know what a ventilator is. That's a breathing machine. He was like, oh, I hadn't thought about that. Okay, would you like to have a pacemaker put in? Would you like to have IV therapy? Would you? He says, now, wait a minute. That's a lot of different things. I said, well, you did say that you wanted everything. So I'm trying to go through the list of everything. He says, I think I'm going to have to think about this. So it's those types of explanations that we need to give patients and families instead of handing them a 10-page document and saying, I want you to sign it.
Right. And just to add too, conversation shouldn't be happening in the hospital bed. It should be happening when you're 18 and up. You can fill out a healthcare proxy form. And that's when it should start to happen. When you're going to college, different life transitions, as Elena mentions, getting married, you need to start having these conversations with loved ones throughout the lifespan. And I think when if the first time you hear the word hospice is right after you're diagnosed with a terminal illness, it's hard to take in all that information. So, Lillian did an amazing job, as she always does, explaining all those terms, but the goal is to get those terms out there as early as possible. So they're not like, what, palliative hospice? I'm getting confused. There's myths, I'm unsure, but just getting all that information out in earlier and easier spaces.
Yeah, primary care.
Mm-hmm.
Primary care, if they ask you, your first visit, first physician. So tell me, who's the person that's going to make your decisions? It's just as simple as that.
Mm-hmm.
Instead of, if we're asking when they're in the hospital, it's already too late.
Yeah. I think one thing that I've seen in my own work is, I'll start these conversations around advanced care planning and I'll say, what would you want if something happened to you tomorrow? And then they'll start talking about, being in the hospital and having an advanced disease. I'm like, no, I mean, literally tomorrow. I think that a lot of the time folks are thinking that we're planning for this kind of imaginary future, but they can change, plans change, wishes can change. And so it's important to keep having these conversations. And I think it's easier for us to think about what matters to us today if something happened tomorrow than, what we imagine might happen in a year from now and a few months from now even. And I think also, Missy, a lot of these decisions and a lot of these things that people will talk about and have to think about require conversations with clinicians who can explain them properly. And I think I so appreciate that you brought up primary care, because one, I think, they're in a better position to be able to have these conversations preventatively, to be able to educate folks on what these things mean and why it's worth thinking about. And then also, Ayana, to your point, it also means that it's coming up in conversation, and it's not just when something big has to be decided, but it's coming up in kind of, in a way, I would say almost normalizing it if it's part of preventative care and primary care too.
They're asking a lot
I
of
think
things.
I'm back.
You're back?
Yeah.
Can you
Okay.
hear me?
Yeah.
Okay.
They're asking a lot of things on admission now, on initial assessments. And just imagine if that was to be added to an initial assessment for a nurse practitioner or a physician, that would make the big difference. One of the other big things is a cultural assessment. Who is the person that's going to be the decision maker? What is the cultural belief? What is the cultural practice? Do they use indigenous healers? Is there going to be a cultural practice? Is there a medicine man involved? All of those things make a big difference. And sometimes if you don't ask the question, you won't know until the person becomes very ill, and then a medicine man in a costume shows up at the hospital and everybody is all upset about it. But if you ask those types of questions, then you have preparation, not only for the medical staff, but also for the patient, because they're looking for their cultural person to come to support their living, their health, and their dying.
Did we lose Lydia again?
Are you with us?
I'm still here, barely.
Okay.
So I thought Ayana was going to say something, which is why I didn't jump in.
Okay.
You can go to the next question. Yeah, I have lots of thoughts, but I know you have a long list of questions.
Lillian, go ahead. I'm going to actually let you just drive this one because I'm not sure that I'm going to be able to stay in.
Okay. So I use the term misconceptions a lot and myths too in the presentation. And so around end of life planning and care, we talked about some barriers to advanced care planning, but what are some common misconceptions and myths that you've come across around all of these topics, advanced care planning, palliative care, and hospice?
One of the biggest barriers that I see in the Black community is that when you go into hospice, that means you don't receive care anymore. What they don't realize is that you actually get more care and that you actually live longer. Most people live longer once they're in hospice because their symptoms are managed better. So, and they feel like, you know, it's some type of misnomer that when you don't want aggressive treatment, I guess the belief is that you don't want any treatment or they don't give you any treatment, when that's really far from the truth. You're getting symptom management, which is a big form of treatment. That's one of the biggest things that I see. And also that you're giving up. That's the other.
Mm-hmm. Yeah, and just to piggyback, I think people are referred to hospice so late. So there's like, oh, my aunt went to hospice, she died a week later. Well, she was referred to late. And so she didn't get the full benefit of it. Yeah, it's a place where they kill you, you don't care, or it's someone giving up, all what Missy just mentioned. But I think when properly utilized, it's an amazing benefit. And people don't understand all the aspects of it too, that you have this coordinated care team, there's spiritual support, there's grief support after the loved one passes away. And so I just think there's just no understanding. And then with palliative care, I really think nobody knows what that's about in any way, shape, or form. And just hearing, like you mentioned, Lillian, professionals not knowing the difference, thinking palliative care maybe is drugging you up or only for people who are dying. So there's a lot of confusion there.
Yeah, and I think another misconception that I've heard is, well, can't my, oncologist or cardiologist, kidney doctor, well, can't they just manage my pain? Why would I need palliative care? And I think, again, it goes into this, this team-based work where it's, pain is of course something that's experienced, but there are other physical symptoms too, and other things that are maybe not physical. I mean, it can be upsetting to go through this. You may need mental health support. You may need help having some of these conversations, and they can help with that. And that's a big one too. And I think especially knowing that there are real inequities around pain management, this is also an area where I think palliative care can really step in and step up. I think another myth that I've heard around hospice care, and I hesitate to call this a myth, maybe it's a misconception, is I think, to your point, Ayana, about getting referred late, I think a lot of the time clinicians are uncomfortable having these conversations, and a lot of the time they don't receive sufficient training to have these conversations. And so I think one of the big things that come up is thinking that unless your clinician brings up hospice care, you can't receive it. And anyone can make an initial referral. Anyone can initially reach out to a hospice and say like, hey, I think that maybe this would be of value to me, palliative care, to reach out. And then of course they would make sure that you qualify, that you meet the recommendations and the requirements and work with your team. But I think that's another barrier, is that sometimes, folks just get referred too late. I think, for instance, in New York, the average length of time in hospice is less than 2 weeks. And that's way too short. And there could have been far more benefit received if it had been for a proper length of time. Yeah. I think Lydia.
Lillian, some of that has to do as well with people feeling like they can't go against the physician.
Yeah. Can you talk more about that?
They just feel like it's a hierarchy. and the only person that can go against the physician is them. So for instance, you know, if they don't want to do it, that's one thing. If they don't want to do it, that's one thing. But, you know, if the physician says, you know, well, they said I'm not ready for hospice, then they're just not going to do it. Or they'll say, you know, I don't want to disappoint the doctor. He says I can try one more thing, when even though they feel like they don't want a treatment anymore. The physicians do need to have be able to have better conversations about treatment, whether or not people want treatment, whether, you know, treatment is futile. They just need to be able to have it, and to be able to explain it a lot better and with a lot more compassion, because I really feel that a little bit more compassion goes a long way. And that may be the difference between somebody accepting palliative care and hospice care than not. I really believe that if they had a better, if they understood it, and they understood the benefits of it. You know, if we think about it, sometimes I can remember when I first started working in hospice, sometimes the way that I explained hospice to families alone was the reason why they took it, just because of the benefits. Just because of the benefits. Now they would tell me, oh, so are you going to tell them? Or they say, don't tell them that they're dying. And I would say, well, what I'll agree to is this. I won't mention it to them, but if they ask me, I'm going to tell them the truth. Can we agree on that? And they would say yes. And they were like, so everything is covered at 100%, the bed, the medication, the social worker. Yes, everything is covered at 100%. Most of which was not if they were going to the hospital and all of these other things. So just the services that they received were enough for them to accept. So being able to even explain that was enough for someone to accept the hospice services. Can we at least talk about, you know, what the patient can gain from it? Instead of, I'm not sure how it's being explained, but I'm sure that it can be done in a way with more empathy and more compassion.
Mhm. And I would add to that, kind of elevating, amplifying good stories of hospice utilization. My grandmother used it when I was in my 20s. And so I always had positive feelings about it. And my whole family got to experience it firsthand. And so we're not entering, when we come to make those decisions ourselves, we're not entering into fear of hospice. And so I think if we share those good stories amongst our community, it'll also help as well.
I think, you know, with what you're bringing up in terms of good stories leads into another question. I'll jump in here, Lydia, unless you're here. Around what are some things that we can do? If there are examples of programs or initiatives that are successful, it would be great to hear about them. But, you know, what can we be doing to, I guess, spread the word about these services and these resources, but also support folks in being able to utilize them?
That's a great question. Some of the things that we can do is to reach out to our faith communities and ask them to have their parishioners become hospice or palliative care volunteers, because they know about faith as people of different faiths. They could be Muslim, they could be Christian, they could be Catholic, and we know for sure that people of all faiths will need someone at some point to sit with, to talk to them. Sometimes it might be about faith. Sometimes it could be a veteran that needs another veteran to sit and talk with them. Sometimes it may be, or it could be our neighbors. You know, ask a neighbor, have you thought about being a hospice volunteer? Sometimes all they need is to take a little old lady's trash can down to the end of the driveway and bring it back at the end of the week. Is those types of things that really make the difference in the life of someone who wants to pass peacefully at home. That may be the one of the few things that they need to be able to do it. Also, the utilization of end-of-life doulas. Doulas are important. Doulas, you know, help to bring the family together, help get things in order, things that, you know, the hospice may or may not have time to do. So that I'm sure Ayana got some other things she could think of.
Well, I am a public health person who, yes, loves to create programs and think about ways to engage people kind of where they live, work, and play. Don't expect people to come seek this stuff out and bring it to where they live and to people they trust. And so you can do that. I mean, Lillian and I did a lot of programs at senior centers and libraries and faith-based organizations. But I feel like social media is also a very powerful tool. I just spent the past week with the African American Leadership Council of Compassion Choices, and they are a group of phenomenal end-of-life advocates who make this information accessible. And so a lot of them are doing podcasts. There's a phenomenal woman. She goes by the Grave Woman. Her name is Joelle. And she really, she's a funeral home director, and she has these conversations and makes them accessible. She helps people figure out funerals that are kind of green burials or rock. She said there was a rocket, someone wanted their ashes shot up in the sky. I mean, but she has a lot of fantastic resources, including even thinking about how we take care of Black bodies after death in terms of hair and our locks. And your typical mortician doesn't know how to get our coloring right. And so just even thinking about those kinds of things. Another fantastic person is the president of the one of the end-of-life doula associations, Ashley Johnson. She has a fantastic TED Talk. So just, you know, sharing this on your various social media platforms, it's a great entry point to start the conversation. The Conversation Project, Compassion and Choices, they all have these amazing resources. The challenge is nobody knows about them. And I was just talking to a friend whose mother's at the end of life, and he was going through this experience. He said, when I'm done with this, I'm going to make a PowerPoint and I'm going to present to my friends. And I'm like, you don't have to do that. There's a million resources out there. It's just kind of challenges around getting them in front of the right people. And Lillian can share some of these resources that I'm mentioning. There's another therapist, Nyasha Grayman, who specifically provides anticipatory grief support to Black women who are dealing with caring for a loved one at the end of life. And there's just so many things out there that create support and resources to help folks. But I like to be creative in everything that I do in my public health engagement. And so we did a comedy show where we had comedians often talk about pain and loss, but in a way that's palatable. And so thinking about different ways to do that, I think, is important. And so as you think about your programming, you know, hopefully we can share some resources of folks that you can bring in to speak. I also think we haven't talked about the financial implications. A lot of Black generational wealth is lost when we don't have wills. And so thinking about future financial planning, there are a lot of free will services. There's Association of Black estate attorneys and estate planners, and just kind of tapping into those local resources and having events and amplifying the amazing work they're doing. And then also Bishop, I think her name was Mackenzie, was just kind of these questions that we can all pose just amongst our own social circles in terms of maybe take time to write your own obituary. And what would that look like? What do you want things to look like the day after you die? Will people know your passwords to your Facebook and your Twitter and your Instagram? Will they know what to do with your stuff? Will they know how you want your children to be raised? And so just kind of these conversations, bringing them up, you know, next time you're hanging out with friends at a brunch, just bringing up some of these opportunities to think about the future in terms of yeah, how you want to be remembered. Do you want even your social media to keep going so people can wish you happy birthday every time your birthday comes, or do you want it shut down? And just sharing this with someone so that they know, so that they can share it with your loved ones. So a lot of answers there. And I'll give all these resources to Lillian, but I think these folks who are doing amazing work need to be amplified and celebrated and invited to speak at your various events.
And I just want to add a little bit more about doulas. So when we had our webinar, I think in the spring, we talked about maternal health, and doulas came up, you know, from on the birth side. But Missy, I appreciate that you brought up doulas. And there are a growing number of end-of-life doulas, and I will send around those resources. Also, I want to acknowledge that. And when I send around those resources, I'll also include the link to 2 organizations, one that Ayana mentioned, NADA, and another one, INELDA, where they list end-of-life doulas by area. And so end-of-life doulas are non-medical support, but they're there for you for emotional support, companionship, in some cases, spiritual support. And what I think, you know, really, I think is beautiful in particular about end-of-life doulas is, especially at the end of life, you know, there can be just so much going on that it can be easy to I think have space closed for certain conversations, for reflection, for legacy work. You know, for instance, one thing that I know some end of life doulas do is they'll help you write your legacy, or they'll help you prepare an album showing all of the photos throughout your life, you know, and thinking about not just what matters to you now, but also what you want to leave behind. And also focusing on rituals, like what do you want the space to be like? What matters to you in the space? Are there sounds, smells? Are there foods? And so again, they're really there not to replace any kind of medical care, but as a different form of care to support you as a person and family and loved ones going through this process, and honoring that process and whatever that looks like for you. And that will look different from person to person. And so I'll make sure to share those as well.
Yeah, companionship and sitting by the bedside, but also going through your stuff and helping to clean out your home and your assets. So yeah, they can. And we know a phenomenal doula who does a fantastic work with. She does a group called Black Folks Grieve, and does a lot around breath work, and just taking a moment to breathe and helping you work through some of that. So, and I believe, Lillian, there's a large population of African American doulas out there. It's going during COVID times, Latino and African American folks who are really wanting to support their community.
Yeah, please, Missy.
I'm a doula.
You are?
Oh, I didn't realize that.
Have a doula here with us.
This woman wears a billion hats.
And you know, I did it because I feel like it resonates with African Americans, because during that time, especially older adults, because I work with mostly older adults, they worked with medicine women, women that came to your house. Like my grandmother used to go to people's houses, deliver babies, make salves and all kinds of things. So a doula is a person that would resonate with an older adult. The way that they talk to them, giving them tea and, crackers and things like that. Nothing really big, just really talking about what's important to them. And that was one of the reasons why I decided to do it, because it's more of a traditional role.
Right. I think I read something that said maybe the term death doula is new, but the practice has been around for hundreds of years.
That's right. Yeah.
And folks, we welcome your questions. Feel free to submit them in the Q&A box. You can also put them in the chat, but we recommend the Q&A box. And we look forward to hearing from you. I think going back to projects, I know another project that Ayana and I worked on was focus groups with Black New Yorkers, who I think we're all professionals working also with Black New Yorkers. And I think, because there is some variation in terms of what resources are available from place to place and what some of the barriers are. Again, there are some commonalities, especially just lack of information being a big one. And I think that was, certainly useful for our organization. And I recommend, even it doesn't have to be that formal, but I think part of having these conversations is also the listening piece, listening to what matters to folks, but also listening to what they need. And so I thought that was a great project. And I think, in terms of things that could be done, one simple thing is just having copies of some of these forms available, like especially the healthcare proxy, or it's also called, again, healthcare power of attorney. I think almost all states have their own form. They're free in many cases. If you ask for them, they will mail you print versions of them, or you can download them and print them. And, again, normalize picking your person and having these conversations. And I feel like sometimes even though that's a big decision, and again, it's not a permanent one, but it's a big decision, I think that can feel a little bit more accessible than having to think about, all of these other choices or wishes that you may need to communicate, with that person, and also with your other loved ones, right? Like, I think it's a good idea to make sure everybody's on the same page, even if you complete this form. But I think just as a first step, this can be useful. And also, I think, Ayana, something you said earlier that I've experienced, I'm sure Missy, it sounds like you experienced this a whole lot, is I thought going into this work that, like you, Ayana, when I mention it, that it would be kind of a downer at a dinner party, but actually it sparked a lot of conversations. And I think because many of us have gone through experiences of loss and grief, and we're just not invited to share them, and it kind of feels shut down a lot of the time. And so I think, by bringing it up, often I think a lot of folks are worried about it, but it often leads to some really incredible conversations. And what I found is often if you speak to one person about these things, it never just stops with them. They'll share it with other folks, and it really creates this community. And so that's another thought that I had there. And so in thinking about programs, and this is a big one, and you may not know the answer to this, that's okay. But if somebody said to you, we will give you unlimited resources, all the funding that you need, all the resources you need to do one thing to make a difference, and again, getting this information out there, or supporting folks and accessing this, is there an idea that you have that you would just love to see happen?
I've already started my idea.
Oh, I want to hear about it.
So I develop a training program. My training program involves tools for the health, and my training is for healthcare providers to help them have better conversations surrounding end of life. And the tools are the end of life deck and the death deck. They were developed by two social workers, Lisa and Lauren, and you can get the deck of cards from the deathdeck.com, and you can play it like a game, so that if, as a healthcare provider, you're seeing the patient or the family on a regular basis, you can just pull out one of the cards and ask them. So one of the questions is, when you die, would you like your funeral to be announced on social media? Who is the person that you would like to make your arrangements? Those are the types of questions that are on the cards. All very important questions. It's another deck of cards, and I think the deck is called the Hope Deck. And one of the questions on the Hope Deck is, and this is when you're having personal relationship with the patient. The question is, what is something in your memory that will forever make you laugh? Now, I love that question, because I know that if a patient told me that, if I went to their memorial service, I know for sure that I would get up and say it at their memorial service. They told me that such and such happened, and that they would always laugh about it, because that's something that would connect me to the patient, something that they shared with me, and it's something that probably everybody in their family would know. So it's those types of things that make it personal, something that takes the edge off, something that gives you good information, about the patient and the family, and something that connects you to, we need to be connected to people, not just, we don't need information. We can get information from it needs to be a connection so that they understand that we care about what it is that they want. So that's what I do for the healthcare professionals, use those. And also is some websites that you can use. One is Granite. Granite is one of the websites. You can go on Granite, and Granite will help you plan everything from during life and then even after death, even with grieving, getting your will together, getting your paperwork in order, all of those different things. And also for healthcare professionals, it's a website and it's called Vital Talk. Vital Talk will help you with planning conversations with the family, team meetings. It'll help you with cultural competency, telling families bad news, symptom management. And Vital Talk was developed by healthcare professionals. So it's a really, really good tool. So I have all of those tools together. I have a presentation that I start with. I give them those tools, explain things in a 6th grade language so that they can explain it to the patient. So for instance, instead of them saying to a patient, would you like to be a DNR? I say to them, so I want you to ask the patient, would you like to die a natural death, or would you like something different? Makes a big, say, what do you like? They say, well, no, I think I want something different. Okay, well, what would you like different? And then they can tell them, well, you know what? I think I want them to give me medicine, or I think I want a pacemaker, because then that gives the patient a chance to tell you what it is that they want, something that they saw on Grey's Anatomy or whatever. So, so it is those types of tips that I want them to be able to talk to the patient about, and to see what the patient understands about what we're asking.
And I'll just chime in. I know we're at time, so I'll just throw out my ideas. So I really want to address some of the workforce shortages and get more children of diverse backgrounds interested in health careers, particularly palliative care and hospice. So I would do an initiative around that. And then also, Lillian and I used to brainstorm about something called like a caregiver college. I think when you appoint someone as your healthcare proxy, it's important, but if they're unsure about how to navigate systems, or they don't understand the law, it can be a challenge for them. So just kind of maybe something with you and the person you're appointing can go through some kind of activity together that facilitates conversations, empowers the individuals to be able to appropriately advocate in kind of stressful situations. I think that would be extremely beneficial.
Great idea. Great idea.
It looks like we had a few questions in the Q&A around documents. So in addition to sharing the resources that have been mentioned here, I'll email all of you links to those resources. I'll also email you the PowerPoint presentation that I gave with those definitions. And I'll also include links to where you can find these advanced directive documents. And to answer the question about Spanish, there are many advanced directives that are available in Spanish and other languages as well. And so I'll include information about that. And yes, I know that we're at time, and I could continue this conversation for quite a bit more, but Missy and Ayana, thank you so much, so much for taking the time to chat with us today. This has been a wonderful conversation and a meaningful one, and I hope that it sparked ideas for conversations that you may be having in your own communities and resources. And if you ever have any questions or ideas that you'd like to share, or if you would like to chat more about ideas, please feel free to reach out, and I'm happy to connect you. So thank you so much, everyone, for taking some time out of your day to meet with us. And I look forward to having our next webinar, which will be next month at the end of the month, and we'll be focusing, I believe, on cancer prevention, treatment, and research. So more on that to come. So thank you again, Missy and Ayana. I hope you have a wonderful day.
Thank you
right.
for having me.
Take
Thank
care.
you.
Okay, bye.